The Gerontological Society of America, Meaningful Lives as We Age.
Welcome to this GSA Momentum Discussion podcast titled Addressing Brain Health in the Asian American Communities. Momentum discussions highlight topics experiencing great momentum in the field of gerontology. We're grateful to Genentech, Lilly, Eisai, and Otsuka for their support of the GSA Care Toolkit for Brain Health and today's podcast episode. My name is Jen Pettis, and I'm the Director of Strategic Alliances at the Gerontological Society of America, or GSA. And I'm pleased to serve as the host for today's Momentum discussion. Today, I'm joined by Diane Tai. Diane is the Managing Director for the Milken Institute Future of Aging, where she oversees the strategic direction and operations for its focus on healthy longevity and financial wellness and leads the Alliance to Improve Dementia Care. GSA appreciates Diane's contributions to our brain health work as one of our expert advisory panel members. Welcome, Diane. I'm so glad you could join me today.
Great. Thanks so much, Jen. I'm grateful to be here.
Well, let's get started, Diane, by talking about Asian Americans as the fastest growing major racial group in the U.S. Can you help our listeners understand who we're talking about when we refer to Asian Americans?
Sure. So Asian Americans represent more than 30 nationalities and ethnic groups, with origins from East Asia, Southeast Asia, and the Indian subcontinent. Yet typically, we're categorized as Asian Americans or AAPIs, Asian Americans and Pacific Islanders, for data capture and tracking purposes.
And why is classifying Asian Americans as a single group perhaps problematic for health data, research, and reporting?
So if you classify Asian Americans as a single kind of monolithic population, it really does hide our immense diversity. And this has significant implications for the health and wellness of our communities, especially when it comes to diagnosing and treating chronic diseases like Alzheimer's disease or other dementias. So when you think about it, Jen, where you're born, where one lives, where you work, where you go to school, it really impacts your health outcomes, as all of these factors are closely aligned with income, educational attainment, and access to housing, health resources, to green spaces and healthy foods. But I think there's good news here. The Office of Management and Budget, the OMB, they oversee all the data collection across all federal agencies. And so the good news, in March of this year, they released updated standards that require all federal agencies to collect more detailed data beyond the minimum required race and ethnicity categories. So this is really going to update and create more subcategories for our AAPI community.
That's terrific. So, Diane, you mentioned a chronic disease when we're talking about classifying this single monolithic group that actually has intense diversity. But let's focus on one of those chronic diseases that you mentioned, and that's Alzheimer's. How does an Asian American's risk of developing Alzheimer's disease and other dementia compare to that of other racial groups? And how does this vary among subgroups?
I'm really glad you asked this question, Jen, because, we know from research that Blacks are 2 times more likely to have Alzheimer's disease-related dementias compared to whites. We know Hispanics are 1.5 times more likely. However, we do not have the data or any sense of risk for Asian Americans, despite our being the fastest growing population of older Americans in the U.S. In terms of variability among subgroups, I think there is significant variability. Again, we don't have the data. We have 6 major origin groups, so Chinese, Indian, Filipino, Vietnamese, Korean, Japanese. They account actually for 85% of all Asian Americans. And of course, they're very different and distinct subgroups because of the different languages, cultures, immigration histories, and socioeconomic statuses. Thinking about immigration history, big difference if you come over here for grad school, or if you're a refugee and experience trauma, come over here, or both. So it's really, I think, so dependent on all these variables. And then there are other smaller subgroups, Bhutanese, Nepalese, Cambodian, Laotian. Again, undercounted. We don't know the risk for those various subgroups. So yeah, it's super important that we get to that.
And Diane, you spoke of the variability of risk for developing Alzheimer's disease and other dementia among those subgroups. And I think you've mentioned some of these, but let's talk a little more about some of the examples of what contributes to that variability.
To the risk, sure. We know that there are 12 modifiable risk factors for dementia. Education is one of them. So high educational attainment is the stereotype of Asian Americans. And there are numbers that back this up. 54% of Asians have a bachelor's degree, higher than whites at 36%, blacks at 23%, Hispanics 16%. Yet, the high school dropout rate among some Southeast Asian American subgroups is actually troubling. So a 40% dropout rate among Hmong population, 38% of Laotian, 35% of Cambodians don't complete high school. So if you're just put together in this one data point of high education, you're really obscuring where there may be groups at risk with lower educational attainment. Another risk factor for dementia is diabetes. And we see significant variability in the prevalence of type 2 diabetes. It's ranging anywhere from nearly 35% for Pacific Islanders and Native Hawaiians to 14% for East Asians. And what's interesting about diabetes, as well as obesity, which is another risk factor, is that the BMI cutoff for overweight is 25 and over. For obesity, it's 30 and over. This is all based on people of white European descent. There is evidence to and discussion and guidelines to say that Asian Americans, should maybe look at 23 as the BMI cutoff for overweight and 25 for obesity. So we think there's probably underdiagnosing of both diabetes and obesity, which are risk factors for dementia. And then lastly, I would say, when you think about social determinants of health, income is another factor. And similar to what I described in the educational attainment, if you look at the median household income of Asians, it's the highest among all racial and ethnic groups. But what it doesn't tell you is the economic insecurity by some subgroups. So you've got poverty rates of 40% among Cambodians, 30% among Hmong Americans. Again, if you're just looking at medians or averages, you're obscuring what might be happening with some of our subgroups.
Well, Diane, you mentioned missing diagnoses of perhaps diabetes or obesity, but let's talk about diagnosis of Alzheimer's in Asian Americans. What are some barriers that may prevent Asian Americans from receiving an early, accurate diagnosis of mild cognitive impairment or dementia, as well as appropriate dementia care?
It's a really good question, Jen. And I don't think there's an easy answer. I mean, generally, there's a lack of understanding about dementia, not just among the AAPI community, but just the general public. Within the Asian American community, Alzheimer's disease in particular, might be perceived as a mental illness or maybe embarrassment among certain Asian subgroups. There's cultural stigma that really might deter people from seeking information or seeking a diagnosis. And then I think most will not report symptoms of dementia to a medical professional unless some family members require them to do so. So that's one, the overall lack of understanding. I think two is there's cultural biases when it comes to cognitive testing due to the inadequate translation of the tools. So if English is not your first language, and we know there's some subgroups again where English there's less proficiency, and so that is also a factor in terms of the tools. And lastly, I do see there's evidence for unconscious bias as another possible reason. The Alzheimer's Association reports that 34% of Asian Americans report experiencing discrimination when seeking Alzheimer's care. And this compares to just 9% among white Americans. Again, is that because of language issues? Who knows? But that's a big opportunity, I think, for us.
So, thinking about the primary care team in particular, what is their role? What can they do to address those barriers?
Yeah, there's a lot of emphasis on trying to get primary care teams to be involved in earlier detection, diagnoses, even high-level screening. What I think they can do is be more cognizant of some of the potential language barriers or not having the cultural competency. We have a shortage of bilingual medical professionals as well. Just that awareness, right? Another thing I think primary care practices can do, oftentimes you'll see an adult age child accompanying their parent to these exams. I know I've done that many times. And really having those children, as well as the older adult themselves, be aware that if you're having a memory issue, that doesn't necessarily mean that you have dementia. There could be other causes, a thyroid issue, vitamin B12 deficiency, sleep apnea, my favorite, hearing loss. We know that hearing loss happens as we age, and hearing loss actually is a risk factor for dementia. It closes down your world. It could lead to greater social isolation and loneliness. And so even just being able to be open to having that conversation about how's your hearing, that might be a way in instead of just saying, are you having memory issues? I say all of this, though, recognizing that there's so much time pressure in primary care. So we can say what's good for primary care teams to do, but also we need to be sensitive that they're dealing with so many requirements right now. Yeah, so I think that's pretty much what I think our primary care can be doing to help.
Well, Diane, this has been a great discussion, and the information that you share about how many diverse groups there are, and then the diversity within those groups even, and how important to identify the subgroups beyond the kind of 6 major origin groups that you mentioned.
Mm-hmm.
And then how different those risk factors that we think of when we look at, if we talk of, again, the Asian Americans, here's our, the higher income, but then look at, again, those subgroups. So how important it is that OMB has started to take some steps to improve the data. That's terrific.
Just so, and I say, not only in start collecting that data, but imagine as we begin to do that, it's going to inform the care needs in the communities, which we all know being underserved. So I'm really excited about that initiative.
That's terrific. What are some other things that you'd perhaps want to leave our listeners with today? Final thoughts.
I think let's put the stigma aside and just know that screening for brain health is something we should all be doing, not just at 65 at your annual wellness visit, but just as a practice. Brain health is something we should all be thinking about, a cognitive screen as a baseline, and then repeating it every year. And knowing that just because you might have cognitive impairment does not mean you have dementia, because we know there's some addressable causes, like I mentioned earlier.
Yep. So normalizing those conversations in primary care, but understanding that time is of the essence. So making those conversations productive is so important. And by making sure folks feel comfortable and welcome and addressing that cultural competence. And I think just the awareness, right? The mindfulness of challenges that people face and how important it is to really stress that and have that understanding. So Diane, I want to thank you so much for joining me today and for all your contributions to GSA's brain work and actually our obesity work too, our brain health and obesity work.
Thank you.
We appreciate your participation in our work. And thank you also to all those listening to this episode of the GSA Momentum Discussions podcast. We hope you found it informative and enjoyable. Have a great day, Diane.
Great. Thanks so much, Jen.
The Gerontological Society of America was founded in 1945 to cultivate excellence in interdisciplinary aging research and education to advance innovations in practice and policy. For more information about GSA, visit geron.org. GERON.org.